Hey guys, sorry I was a couple of minutes late. I was busy editing the photos that were going to be popping on online, so on the screen. So I had to do that quickly before we went live. It took me a couple of minutes longer than I thought it was going to be. Today we've got Kreena on again. If you guys haven't already seen the first time round with Kreena, it was really good. One of the more informative and kind of intense sessions we did. We just went through everything that you could think about doing a retreat in endo. Today we're going to look at Perio Endo, but we're also going to maybe let's have a little bit of a chat, see what's going on, and go through a couple of bits and pieces. Any questions that you guys have, that'd be great. Karina, hey, how's it going?
Hiya, how are you?
Good. I was racing against the clock there to edit those photos.
Probably my fault. I sent them to you a little bit late.
Yeah, and then it just took me ages to get the damn thing to download.
Oh no.
I took screenshots in the end, and then sent the screenshots from my iPad to my phone, and then back, and all sorts. So it's done.
Oh,
It's the
sorry.
main thing. And they look really good. So let's pop our cover on because we have a cover today. How cool does that look?
Wow, yeah, very nice.
Um, so yeah, last time out, I was just telling the guys that last time out when you came on, it was one of the more kind of, I think we went through anything you could possibly think about when you're going to do a retreat. It was unreal. I think a lot of guys kind of picked up a lot of things for that. There's guys going through finals right now. Anyone who's watched that probably learned all of endo in 1 hour. So thanks
Well, I'm
for
glad it was
that.
useful. It was nice. It was nice chatting to you.
Yeah, have you managed since the last time? I think it's about 4 or 5 weeks since we spoke
Yeah.
last, wasn't it?
Yeah, no, it's been good. I mean, this last week has really been sorting the practice out and getting it ready to sort of reopen. So
Mm.
just had a lot of staff training and putting up our perspex screens and trying to sort of order shields from my microscope and things like that. So done a lot of staff training this week about how sort of our operating procedures are going to be when we get back. So it's been a busy week actually.
That's an interesting point actually, because um, how are you going to keep your scope clean and stuff?
Yeah, so I ordered I made some sort of rough dimensions and ordered a perspex shield for it. It's
Yeah,
basically something that just goes over the eyepieces and covers sort of the rest of the area. So any sort of spray back will go onto the shield rather than me or my
your face.
nurse. Um,
Yeah,
but the measurements I did were slightly shorter than what I wanted, so I'm having to remeasure tomorrow to get it ordered again for next week. So I get a bit of trial and error, but because I'm making my own, I think it just needs a little bit of playing with to get it right.
yeah. I'm trying to find the photo actually, but my the manufacturer made mine. They've come out with something,
Okay.
and it looks pretty good. It looks a bit small for my liking, to be fair.
Yeah.
Um, and it doesn't cover the nurse's side. But
Yeah.
she'll be wearing a full face shield. She doesn't need to see down any of the eyepieces or anything because we've got a screen ready,
Yeah.
so she can see that.
Great. Yeah.
Um, I can't see.
When are you back? Have you decided?
Um, I'm very hesitant to go back. To be honest, I live with my grandmother. She's got a lot of health considerations, so we've got to be really careful with what we do and don't do. So
Yeah.
um, I don't know yet. I'm kind of weighing up the pros and cons at the moment. So
Yeah.
obviously we just had the letter today. So I've been calling friends, going, "What are you guys doing?"
Yeah.
Uh,
I
and we're just like, "Oh God," it's kind of taken
think it's the
everyone by
mask
surprise.
situation that's one of the hardest ones, isn't it? Because to source everything and get everything fit tested is going to be a bit of a difficult thing in a week for a week. So we'll see how it goes.
God, that's not what I wanted. Where's it gone?
Oh,
Um, I can't find it.
that's all right.
Um,
You can send it to me after.
yeah, no, but it's perspex. It goes around the eyepieces and one around the lights. You know, the actual light unit at the bottom. So
Yeah.
kind of a double protection, but they do look a bit small. So it's going to be interesting.
Yeah, the one I
Um,
made was definitely too small because I thought you need a little bit more room to work with, but actually I think the shield can be quite large. So I'm going back in and sort of remeasuring tomorrow to see what I can get away with doing a
yeah.
bit bigger.
So I don't know if you've caught any of the ones we've been doing recently. Um, we've had a really, really important addition to what we do now. You've got to put down your 5 most used emojis.
My Oh God. So
So finally
I
going up again, and they change daily actually, which is interesting. So guys, those are mine. We're
where
gonna
are
see
your
what Kreena has.
do I need to put them in?
Yeah, go for it, guys. In the comments, let's see yours as well. We're going to talk Perio Endo today, so that's kind of probably where we want to dive in. I want some questions as well from you guys who are watching. What kind of issues or questions you have with Perio and Endo, combined lesions, issues that you've come across. You used to fish more often than anything else.
I quite like that fish. It's been a since Corona lockdown one that I've quite enjoyed.
Mine's been that one. That's all
Oh
I've
yeah.
used since Corona, I think. But yeah, so this case that we've got in today, let's have a little look at that, and then we can chat a bit more after as well. First slide. Here we go.
Great. So, I mean, I think when we're talking about Perio Endo, the first thing that sort of pops into my head is the classification that I use. And I mean, it's not really to do with the new Perio classification that's come out. I sort of find it very easy to use how we sort of describe it in endo. So for me, it's sort of it's either primary endo, which we can go through, and which this case mainly is, primary perio, or we're looking at a combined lesion. So it's either primary perio, secondary endo, or primary endo, secondary perio, or a true combined lesion. So I think just starting with this one, it's obviously this is a a primary endo lesion.
Yeah.
And it's a little bit confusing actually to differentiate what a primary endo lesion is compared to a cracked tooth. So what it means is that the infection that's associated with that tooth is fully due to the root canal space. But if we look at the radiograph, there's a J-shaped radiolucency there. So it's quite easy to jump and think, okay, this is a cracked tooth. And you wouldn't be wrong to sort of, really
maybe
consider that, because we're looking at a last standing sort of molar, because the wisdom tooth was out of occlusion. We've got this J-shaped radiolucency. We've got a large amalgam present. So, it very well could be a cracked tooth that we're seeing. But if we look a little bit closer, we can see that I've traced the sinus on the distal aspect of the tooth, and it's coming from the base of the distal root. So that's all that's happening is the infection has got large. Large infections like to drain through the easiest path of drainage, and particularly in the lower mandible, because the buccal cortex is so thick, the lesions quite often want to drain either through the furcation. So that's the picture more on the right hand side, where we can see there's a pocket going into the furcation and an abscess in the furcation area, or via the ridge. So like we're seeing in the first photo on the sort of left hand side, and that's purely because the cortex is so thick. So although for upper teeth, for example, or anterior teeth, the easiest path of drainage is through the apical aspect. We get a buccal abscess near the apex of the tooth. For lower molar teeth, it's not the same thing. So sometimes we do see these narrow isolated pockets or J-shaped radiolucencies, and you have got this communication between the gingival margin and the base of the tooth. So it is sort of a perioendo lesion, but it's primary endo in its nature.
Yeah, I think that's probably a really useful kind of tool, the GP sinus tracing. You can see where it's coming from. But if you do that, how can you differentiate? Is that going to help you differentiate between the primary perio and the primary endo?
Well, I mean, for the first case, we can see that there was a sinus distal to the tooth. So tracing that, I think, is quite useful just to see where it's coming from. So I think if you've got a sinus on the ridge area, you're more likely thinking it's a primary endo lesion. Whereas if you've got a narrow isolated pocket, that could still be a primary endo lesion, but you'd be a little bit more, hard pressed to know if that's a crack or not. So, for example, in the second photo on the right hand side, there's a crown on that tooth. There's a narrow isolated pocket. So that very well could be a crack, and we wouldn't know until we removed that crown and had a little look, because both primary endo lesions and cracked teeth can have narrow isolated pockets. associated. It's
Yeah,
just that
yeah,
you shouldn't jump to the fact that it's a cracked tooth when you see these sorts of signs on lower molar teeth, because quite often they do drain through this pathway.
yeah. You probably, before you decide that, unless you can see the crack, first off, you probably want to access, because you can see, some periapical pathology. So
Yeah.
obviously, then if you access and you see a crack running through the floor of the pulp chamber, cool, out it comes. But you can't be sure until that point. So yeah, I would agree there.
Yeah.
I don't know if this is a bit of a cheeky question, but does it matter whether something is a perio first lesion or an endo first lesion? Is the treatment going to be that much different? You're still going to do some endodontics to clear up whatever's in the tooth, and you're going to do some perio to stop whatever's around the sides of the tooth as well.
Yeah, I mean, it matters like quite significantly, because the prognosis is totally different for both of these. So if it's, for example, here where this is of endo origin, this tooth, and it's primary endo, there's no perio involved. This tooth will only need endo treatment, and the prognosis is pretty good actually for these sorts of lesions. I would say for something like this, probably 75, 85%, something between those ranges. So it's very, very good. Whereas we're going to see cases later on which are primary perio in origin and secondary endo in origin, and actually their prognosis of those cases is very, very guarded actually, because we know our endo treatment tends to work quite well, whereas when the perio is that significant that it's caused an endodontic problem, the long-term prognosis for that tooth is very, very poor. So what you tend to tell the patient will be completely different things. And we manage them differently. So if there isn't a perio involvement and it's just primary endo, we're not going to be carrying out any endo treatment for this at all. So for this case, for example, if there was a pocket, you would do the endo treatment, and you wouldn't want to actually do any perio treatment at all, because I mean, because you'll get full resolution of that perio issue, of that pocketing depth, because the cells that populate that root surface are still there, so you'll get full regeneration of that space. Whereas for a perio lesion, you would be doing some perio treatment afterwards. So for example, I know we're going to come on to it a little bit later, but for combined lesions such as primary endo, secondary perio, we would always do the endo first. And then we actually wait 2 to 3 months just to see what sort of healing we get from the endo part of things. And then we would do the perio treatment of what's left, because the last thing we want to do is remove any cells from the root surface that could potentially regenerate that, because then we're going to form a long junctional epithelium, and that's not good for the patient long term. So if we can try and get as much regeneration as possible, and then do the cleaning of what the perio part is, it's a lot better.
Yeah, I'll just say that I'm asking these questions as devil's advocate. I'm not actually completely.
Yeah, no, of course, I know you are.
I'm just thinking the way I said it, I was like, does he sound like a moron there?
No.
But so you're going to be looking at, for example, you've taken a PA. Is the bone level a bit dodgy the whole way through? Have you got pocket depths everywhere? On other teeth as well? That can give you that idea of actually it's a primary endo, or actually it's a perio issue, and then you can tailor your treatment along those lines. And of course, like you said, you don't want to scale away those cells which are going to reform your periodontal ligament and reduce that pocketing depth. I just thought, oh god, did I sound really stupid when I said that question?
It's an art when you interview, isn't it? Because you want to get the points across, but
yeah.
Yeah.
Sanchez had a question actually. What's the ideal magnification used for perio and endo in general practice?
I mean, when I do the endo part, because I wouldn't do the periodontal part normally, I will work with a colleague who will do that. But for endo, I'm using a microscope, so probably 10 times magnification for the endo part of things. And then I'm not sure what periodontists use in terms of magnification, but I don't know. I couldn't answer.
That's a question for when you're online with Reena.
Yeah, we're doing
in a couple
tomorrow,
of days' time.
actually.
Tomorrow. Okay, cool. Yeah,
6
so guys, Kreena and Reena are going online tomorrow, so that'll be interesting. I've joined late, but wanted to know whether the radiograph showing an endo perio or a perio endo lesion. So this particular radiograph was endo first, wasn't it?
Yeah, it's actually just primary endo. There's no perio involvement. It is perio involvement because you've got a pocket, but there's no it's not a primary perio secondary endo, because actually this will heal completely with just the endodontic treatment alone.
Yeah, perfect. Should we have a little look at the next slide?
Yeah.
I've got to scroll back because I was looking for that microscope picture. There we are. So here we have the next one.
Yeah. So I'll sort of walk you through this case because I found it quite interesting.
Sure.
So this upper first molar, I looked at it, and to me, I could see a slight radiolucency on the mesial aspect of the root, but I didn't think too much of it. When I first looked at the tooth, I thought, okay, this is just a straightforward endo disease. It's got a large amalgam in it. That's probably what's caused the pulp to become necrotic. And then I removed the restoration, because whenever I'm treating teeth, I always remove the a coronal restoration completely. And when I did, I saw that there was a pocket. So it's difficult to see on this screen, but you can just about see my BPE probe on the top sort of right-hand surface of that tooth. It's gone all the way. So it's pretty much about an 8.5 millimeter pocket that was present. And it was an isolated pocket as well. So there's, I'm jumping to, is there a crack here? Because you don't often, for upper molar teeth, because the buccal cortex is quite thin, if there is an infection associated with this tooth, we normally get a buccal abscess quite high up. We don't normally get drainage through the PDL of this sort of tooth. So having a narrow isolated pocket there did make me think, okay, maybe there is a crack here. I couldn't see a crack, but I did tell the patient, okay, there is I can't see one, but there isn't many factors here that might cause this pocket to be here apart from a crack. And the patient was like, I really want to try and save it. Just, please carry on. So I carried on. And if you switch to the next one, just.
Yep, let me get that one. Here we are.
That's it. So, oh, not that one. There was one, that's the one. So what we can see here is when I did the obturation, you can just about see there on that mesiobuccal root, there is a large lateral canal, which we can see the sealer has come out of. And so it's that lateral canal that's caused that periodontal pocket. So again, this is a primary perio case, a primary endo case. And that pocket was there because that lateral canal, the easiest path of drainage from there was through the PDL.
It's already in the PDL there, isn't it? It's already a third the way up the route, so it's quite an easy route for it to take. Yeah.
Exactly. So that's another reason why we can sometimes get a primary endo lesion, or even a primary endo secondary perio type lesion, because of these lateral canals, because it's any sort of communication pathway between the endodontic aspect of the tooth and the periodontal aspect of the tooth. So maybe don't give up on these sorts of cases. It's, maybe we can get some good results and hold on to these sorts of teeth. So those two were the main sort of primary endo cases I wanted to demonstrate here.
Yeah, that's a really nice kind of, you can't see that on your pre-op X-ray, which we've just popped back on, and then you can see just that little kink on the top third of the root. So it shows that there's so many different ways that this can present, and actually, had you not removed that full restoration and gotten the tooth naked, as my professor used to say, like get all the crap out the way so you can see the whole ring of enamel around the outside. Had you not done that and you just gone in and just accessed through the old restoration, you couldn't have made that accurate diagnosis. Exactly. And then obviously it does make your life a little bit harder, because then you've got to rebuild the tooth and re-wall and things like that. But you can't get the right end result if you don't do that, because there could have been a crack there had you not checked.
Yeah. So. Or you could have assumed that there was a crack with having that pocket there.
And ripped it out.
It's only once you dismantle it that you can actually see. I'm not visualizing a crack, so there is a chance this might be something else.
Yeah, And let's have a look at the other photos. Oh, how do you differentiate between endoperi and periendo lesions? Which intervention to start first? So that's what we were kind of talking about a little bit earlier, wasn't it?
Yeah.
So
So
recap that.
yeah. If it's primary endo, then usually there is going to be a large restoration in the tooth, something that's resulted in that tooth becoming necrotic. And again, the pocketing that you're seeing, it's not a general pocket. You're looking at usually a narrow, isolated pocket. So there's an area where something is draining from the endodontic aspect. The next sort of thing is primary perio. And the way you differentiate primary perio is that the tooth is often vital. So quite often I get referrals from like periodontists or even general dentists saying, this is there's a lesion, a large lesion associated with the tooth, and will you please root treat this? And quite often these teeth can be unrestored. Sometimes they can be restored, but it's really, you see a wide general pocketing, maybe some pus coming from the gingival margin. And you vitality test these teeth, and you notice that actually they're vital. What I would recommend is definitely using something that's very cold. So we want something like Endofrost rather than ethyl chloride, which is definitely not cold enough. So I think ethyl chloride is sort of -5 degrees Celsius, whereas Endofrost is -50 degrees Celsius. So you want something significantly cold, that we're going to get a response, because perio, quite advanced perio can cause some sorts of calcifications of the root canal system. So with a standard test, you may not get a response. I also think EPT is also fantastic for these cases, because quite often in practice I find actually they're not responding to the cold testing, but you put EPT on there and they do respond. So you can differentiate primary perio from primary endo from just those sort of basic tests. Obviously with primary, if it is a primary perio case, sometimes you do see a radiolucency around the apex and things like that, but because the tooth is vital, you doing an endodontic treatment on that is not going to do anything to help the prognosis of that tooth. So we wouldn't.
The source of the infection has still been untreated, so you're not going to see that resolution. And I think if from my kind of understanding at the moment, obviously you've got a lot more experience than I have, and people like Rena as well. I always try and think of where is the infection coming from, as opposed to where maybe the symptoms are.
Yeah.
Because if you go, okay, well, what's the root cause of well, pardon the pun, but what's the root cause of the actual issue? And you go and you kind of think about it a bit more and go, actually, there's pocketing everywhere, and this one's just particularly bad, and now there's a periapical lesion, but we have 7mm pockets across the mouth. It's probably a primary perio and lesion, as opposed to this has got now devitalized and needs an endo.
Yeah, definitely. Looking at the whole mouth is, key for these sorts of diagnoses. I think it becomes a lot more difficult to differentiate and diagnose the lesions that are combined. So primary perio, secondary endo, and secondary endo to primary perio. Those things can be a lot more difficult when it comes to diagnosis, because the pulp is necrotic and you've also got some perio involved. So those can be quite difficult, and some of it is a guessing game for those sorts of lesions. And again, looking at the rest of the mouth is really useful and can help.
In your experience, when you have a combined lesion, does your vitality testing and percussion testing, etc., is that still pretty clear cut, or does having the perio disease kind of obfuscate the results of a vitality test at all?
No. So obviously, if they're a true combined sort of lesion, or even any sort of combined lesion where it's primary perio, secondary endo, or vice versa, the vitality test will be negative. And so it's very difficult to differentiate where the infection has come from first, quite often.
Okay, that makes sense. Hopefully, Alkesh, that's answered your question. Just let us know if there's anything you're still unsure of. We've got a question from Ismail. He's asking, would you take CBCTs in these cases after removing the restoration? I would say probably not. Certainly not to check for lateral canals. Is that something that you would agree with?
We could actually, in a case like this, because what it would have highlighted is that there is a distinct radiolucency in the mid-third of the root.
Right.
I didn't, because I think sometimes it is difficult with CBCT, because this would have shown probably a J-shaped lesion, maybe not involving the apex as much. So it would have given us a little bit more information. Again, it was quite a large lateral canal, so we might have actually been able to see the lateral canal on this particular case, just because it was very large. But in most cases, we can't see lateral canals on a CBCT. But yeah, I don't tend to do it for this sort of thing.
I was more kind of asking whether you would actually take it. So he's maybe saying mid-treatment taking it to check for a lateral, as opposed to pre-treatment to see what's going on.
Yeah, I mean, some people do take mid-treatment.
Okay.
Mid-treatment, it does give you a little bit more information at this stage. But I mean, I couldn't see a crack. You can't see cracks, fine cracks on a CBCT. There's, a lot of evidence which shows that if there was a crack here, we wouldn't have been able to see it on a cone. Sometimes fine, fine laterals we can't see on a cone beam CT. So in this case, maybe we would have got a bit more information because of the size of the lateral, but actually in most cases probably wouldn't have got a significant amount of information at this stage, I would say.
Yeah, cool. I think that makes sense. Any other questions? I think Alkesh said that he's happy with the answer. I think he's clocked it, so that's brilliant. Armour is saying great tips in diagnosing. Anything on the tab? No, let's have a look at the final slides.
Yeah.
Was it this one here? I think it was. Yeah.
So this was a combined sort of lesion. So this one was a primary perio secondary endo. So the one that I talked about has the poorest prognosis. So what happens is with primary perio secondary endo, you've got significant perio disease, and the bacteria have reached the tooth from either sort of lateral canals or large tubules, dentinal tubules, or more often through the apex of the tooth, so from the apical foramen. It can also have happened, so for this patient, he'd had a lot of perio treatment from a periodontist before, and obviously with perio treatment, they're trying to do root surface debridement to stabilize the perio, and sometimes that treatment as well can sever the blood supply from the apex of the tooth and result in pulp necrosis as well. So this tooth definitely has a guarded long-term prognosis. It was slightly mobile, in fact. I think it was sort of grade 1 to 2 mobile. But this patient was under the care of a periodontal specialist, really motivated to keep his teeth for as long as possible. He'd been spoken to by the periodontist and said, these teeth don't have a great long-term prognosis. We don't know how long they'll last, and they're definitely sort of on their way out. But if you want to keep them for as long as possible, we need to maintain excellent oral hygiene. And have regular perio treatment, and he'd complied in a really good way. So he'd was completely compliant. His oral hygiene was absolutely fantastic. He did still have some pocketing. So when I saw him for a consultation, I said to him, this is primary perio, secondary endo. We can do the endo treatment, and the benefit that we'll have is, say you're having perio treatment, we've no longer got an endo source of infection, which maybe is causing the perio not to work.
You've removed that reservoir.
Exactly. It's not going to regrow your bone levels. It's not going to improve your mobility significantly, maybe very slightly, but it may give you a little bit longer with the tooth. Whether that is months or years, it's difficult to predict, because obviously it's right down to him and his oral hygiene, and how much perio treatment he's having. And so what I did was I did the root. He was very understanding. His aim was just to keep the tooth for as long as possible. And for me, I mean, if it's a tooth that I would save in my mouth, even if it was for a year or two, gives him that function at the back, because a lot of his teeth are poor prognosis here. They all had significant perio disease. And by extracting that tooth, we're then putting more pressure on the teeth on either side. So it sort of, enhances that cycle of potentially he will lose other teeth. So, after that conversation, we decided to go ahead with root canal treatment. So I sort of went in and did the root canal treatment. The tooth was necrotic when I tested it with EPT as well. So, I was sure this was a definite endo lesion with perio. And you can see I kept the access as small as feasible, because there was no
5 canals in there. I was trying to have a little look. I just zoomed in.
A
Because
4 and a little lateral, I think.
yeah, I think the lateral is the one I was going. Is that an extra one there? Because
Yeah.
that looked fun. Yeah.
And this patient had pocketing to pretty much the apex of his tooth. So, and it was generalized pocketing. He had peri in the rest of his mouth. So that's how the diagnosis was formed here. And for him, I mean, the only difference in long-term care is I didn't advise a cuspal coverage restoration. So for most molars, I will, always advise cuspal coverage restoration. But you can see we've kept everything very small. There isn't actually that much pressure he's probably putting on his teeth because his teeth are slightly mobile. So I'm not worried about him sort of trying to crack something with it. So we've, gone for just leaving the tooth like this with a composite core. But it's a very unusual case. I don't normally recommend that sort of thing, but for this, I do.
Yeah, Rashina's asking, did you get any reduction in the mobility of the tooth post RCT?
I treated this patient probably 3 or 4 months before lockdown, so I would have reviewed him, but I haven't had a chance, unfortunately. I do assume it will be a little bit. I never usually tell a patient it's going to improve the mobility because I don't want them to get their hopes up. I'm very sort of frank when it comes to primary perio, secondary endo. I don't treat many cases because of the prognosis of that tooth. An implant is often a better option for these sorts of patients. But here you can see the position of the sinus. He's, if this teeth come out, he's going to need external sinus lifts, and he's a perio patient. He's genetically prone to perio. So that's why we're trying to keep these teeth rather than go for implants. But I would have assumed we would have got some improvement in the mobility.
I think you kind of touched upon something that I'm quite interested in. Alkesh, we'll come to your question shortly, but it's that loss of one tooth leading to more pressure or occlusal force on the rest of the mouth. Are you aware of any I was trying to look this up earlier because we were doing some mock finals with people from Newcastle.
Okay.
Their finals are next week, so some of the guys, I think you're involved with Deciduous a little bit, aren't you? So
yeah.
you know what's going on there. So we were helping those guys, and I was trying to find something that was along these lines, because it makes sense in your head that you lose one tooth, you've lost one pair. If you lose another tooth that's not the opposite part of that pair, then you're down 2 pairs. And it's really, really quite quick to then actually have not very many pairs of actual teeth which are functioning. And then the thought process is how does that really affect everything else? Are we then going to see loads of cracks because there's a lot of force going down these teeth? If they're heavily restored, you're going to see more and more of that as well. Is that going to lead to devitalization? It's just quite it's like a very slippery slope in my mind. And
yeah, definitely. And I think you don't appreciate that until you often hear that from patients, I lost this one, and since I've lost that one, I've had problems with this one, and then I've had problems with this one. And you do think, actually, if you can try and save them and the patient sort of understands that process, it's best to try, really.
Yeah, it's one of those things that you try and get across to them, but when somebody's in pain, I think you're going to be getting a lot of that at the moment with these UDCs, the urgent dental care centres, where the patient's been in pain for a bit too long. And at that point, they just don't care. They're not thinking, actually, if I lose this when I'm 25, within 10 years, this is the first tooth I've lost, I'm probably losing 3 or 4 more.
Yeah, I know you often see it when patients are in pain, don't they? They're like, just get it out. And then you've extirpated it, and then they come back and they're like, oh no, I want to save it, actually, because they're not in that pain anymore, and that mindset of just get it out, anything to make it stop.
Yeah, I think that's the real trouble. Is there any tips that you've got? I know we're getting slightly off topic with the perio endo side of things. Any tips that you've got for those cases where somebody's coming in pain and you're thinking they really shouldn't be losing this tooth? This is a small lesion. It's going to be nicely saved with an endo. How can I make sure that doing this access is going to get them out of pain, and they're going to come back and be accepting of the fact that, actually, we can go with an endo for this one and save the tooth, as opposed to going, just get it out, I don't care anymore?
Yeah. Well, I think it's always better for those cases where you think that, when you're a general dentist, you see that patient quite frequently, and you sort of know their mindset already. If that patient is a motivated patient. So if they're in pain and they're like, take it out, I think it's always it's always better to try and extirpate if you can, just to give them a little bit more time to think about things. And obviously it's the patient's will. If they want to have it out, then at that next visit you take it out. But I think to immediately jump to extraction for those patients that are making a rash decision, in terms of extirpating, I do think that it's all to do with time. So quite often you're treating, you know, if you're in the NHS or even like an emergency that's been fitted in between a few of your patients, even if you're a private dentist, it's quite difficult sometimes to find the time to fully clean and shape that tooth. Especially if it's a hot pulp, because sometimes you know you're entering that tooth, it's difficult to numb up. So I find things like Ledamix or an antibiotic steroid paste really good for getting patients out of pain when they've got hot pulps. I don't advocate it as a sort of an interim medicament, but more as a just to get that patient out of pain when they've got irreversible pulpitis. I just think it helps really calm things down. You barely need to, you know, make a hole in the pulp chamber roof to get the Lidamix to do its job. So I just think that is a really good way of getting a patient out of pain when they've got a hot pulp.
Yeah, I think it's something that we're possibly going to see quite a lot of. So I thought it might be a good idea to kind of cover that as well.
I mean, ideally, with hot pulps, if you can remove the full roof of the pulp chamber and just that coronal pulp tissue, that is the ideal way to get that patient out of pain. Whereas if you've got a necrotic pulp and an abscess, you do want to try and clean and shape the canals if you can, because you want to try and really disinfect the root canal as best as possible. But I think for hot pulps, as long as the coronal pulp is removed, if you put something like Ledamix in there, that is a really effective way of getting that patient out of pain.
Yeah, I think that makes sense. So we went off topic there, and I'm trying to remember what I said, what I was about to ask you, which was back on topic. We'll go with Alkesh's question for the moment. From a clinician's side, in a grade 2 mobile case, do you consider motivating the patient more, or going for a definitive treatment with a confirmed result? So I think he's asking about the perio side. Do you do a load of, OHI, etc., before you'll dive in?
Yes, 100%. Like that I mean, like I said, I very rarely treat primary perio, secondary endo, because it's got such a poor prognosis. You're not trying to get back to healthy, really. You're quite often just trying to extend the life of that tooth. And it's not really the endo that's hard work, it's the perio side that's hard work. So I think if you're a general dentist, you need to basically make sure you've done your OHI, the patient has shown good compliance with your treatment that you're doing, good everything's like pretty much spot on. You need a highly motivated patient who totally understands, has good informed consent that this tooth is not lasting very long, and then you dive into the endo side of things.
Yeah, I think that makes sense. Well, even on the perio side, you're not going to, you shouldn't be doing perio treatment until somebody is motivated, cleaning properly, changed all the factors that are an issue as well. Oh yeah, that's right. Great talk, guys. Studies by Kesa, Witter and Kano would suggest that the loss of posterior teeth doesn't cause dysfunction. I'll have to have a look at that one, man.
Yeah, I mean, I think what they're saying is like, I guess occlusion doesn't enhance perio disease in stable perio. I know that. I mean, perio side of things, I'm not the person to ask, but I mean, I think just looking at this patient, he's got several mobile teeth in his mouth. So the loss of one, I mean, maybe there isn't significant evidence to prove that they will weaken the other teeth or cause increased mobility in the other teeth, but I would assume that losing one here would cause more mobility in the ones, if they're already mobile on the adjacent ones, just because of the increased sort of force you're now putting on those teeth. But there are if you look at evidence, there's always evidence one way and another way. And it's very difficult to do studies on teeth like this, because you have to monitor the patient for a significant period of time. And often clinical studies aren't able to do that in the settings that they're done in.
I think you would have to have some sort of almost like the fluoride review. Do you remember the one that was done up in Newcastle? I can't remember the name of it, where they did a section where it was fluoridated, a section where it was non-fluoridated, went back every 4 or 5 years for, I think it was a good long time they were doing it. It was a very longitudinal study, and then they obviously came out with the results that showed that fluoridation of the water was causing a huge drop in the DMFT scores,
Yeah.
which is now pretty widely accepted.
That's, I mean, that's a fairly, you can, I mean, it's a difficult study to do, but it's, you've got a
mm,
big population there
yeah.
to study. For these sorts of cases, it's
So
difficult to get the patients to monitor that sort of thing right through. You know, to get a whole bunch of patients which you've taken the tooth out and a whole bunch that you haven't, the motivation level between the patients is completely different. You know, there's a lot of fact, their occlusion's different. It's very difficult to monitor. But I think if you would just sort of assume, if it was your mouth, you know,
yeah.
that sort of taking one if you've got 4 mobile teeth in the mouth, you take one of them out, you worry that the others are having more pressure on them.
Well, just imagine if you lost a couple of canines. Let's just say we lost both our upper threes somehow, whether it was by trauma or infection. You now then lost your guidance, so then you're moving your teeth in a very funny way to try and get everything back and chewing properly. So there's been a big change in your occlusal scheme there. So I would think, I know that you'd have to study this properly and things, that it would make a big difference to your quality of life and how you're eating, and then the knock-on effects of the teeth further on.
I think maybe if you get someone who's an occlusal expert, perio occlusal expert on here, it would probably get better answers. Unfortunately, that's definitely not me. I'm more the endo side of things.
We're totally spitballing here.
Yeah.
It would need some sort of like a 40-year review almost, from, you know, kind of adulthood till the grave, where you could work out what.
And I teach over at Guy's, so we're sort of all involved in the clinical research that's you know, we carry out there. And I'm telling you, to get a 1-year recall of above 60% is super difficult, really, really difficult. So
I wonder if technology could help us there, because now if you're coming in, your notes are online. So I wonder if there's some way it could just link up and anonymize the data and say X patient had a tooth out. You know, there's perio or no perio, because we log that sort of thing. And then they could, you know, exclude for factors or include factors. That could be quite useful, but everyone's on a different system. Some people are and aren't logging things, so it's going to be difficult. But I think that's quite interesting. We're getting really off topic here. So Hot Pulp, Harris is saying he'd trust your opinion on the case and depending on the case. So he's thrown his own suggestion of the papers out the window straight away. Favorite anesthesia protocol for a Hot Pulp, because some people are using a combination of lidocaine, articaine. What's your go-to?
Yeah, so I do lidocaine first, and then I usually give so say I've got a patient with irreversible pulpitis. I know that, you know, that temperature sensitive to hot, cold, all that sort of thing. Normally I will give lidocaine first. I will always give an articaine as well. I will then normally blow my 3-in-1 on their tooth, and if they can still feel it, and you know, really hot pulps, they can still feel that. So before I even reach for my drill, it'll normally be a 3-in-1 first, just to check. And then I will give usually an intraligamentary injection, so on the mesial aspect and the distal aspect of the tooth, because that's where the intraligamentary injection tends to be absorbed the best. And I find that intraligamentary really, really useful. I find that, you know, quite noticeable improvement in the pain. Quite often, even if you've given a buccal infiltration with lidocaine and articaine, they will still feel that intraligamentary injection. So yeah, I give that. Once I've given that, usually things are better, and I will usually start my access cavity. Quite often, as you still approach the pulp or make a small perforation into the pulp, they may still feel that again. And I will normally give an intrapulpal infiltration as well. So I'll normally tell them that you may feel this for a couple of seconds. I'm going to do it again. So we're just going to go and do that. And patients really appreciate that. I think if that, you know, instead of them suddenly feeling it without you warning them, you say, you know, you may feel this one, and then I will always give an intrapulpal infiltration. There are other ones, things like intraosseous injections, where you can make a small sort of pinprick drill hole through into the bone and give an intraosseous injection. But I have to say, I've never given one of those, because I've never felt the need to. Usually,
I think you've got to be super careful with those if you go offline a little bit. For example, on the lower, you've got your mandibular foramen. You know, be perforating a root by knocking into the wrong spots. That's I think it works very well. I can't remember who I spoke about it with it about that particular technique. It might have been ABS Endo, actually, ABS Endo. I think he spoke about it very briefly. He says he uses it every now. I think it was him. He says it uses it every now and then. But it's not your initial first off, off the rack go to method. What gauge needle are you using for the PDL?
Oh gosh, I can't tell you the gauge, but it's my small one. It's like the one I use for infiltrations. But I've also got the Perio press gun. Yeah.
Yeah.
Which again is really useful, just because when you're giving those sorts of injections, there is a risk that the glass on the cartridge can burst. So those sorts of guns are quite useful.
Yeah, because we had 3 different ones in university. We had the long one. Again, I think it's 25 gauge for your IDBs, and then it was a 27. Or was it the other way around? I can't remember now. I think it was a 27 and 25 for your block and your IDB.
Yeah.
And then we had the pen one, which was actually really short. It was less than an inch long.
Yeah,
but
that's
micro
the one.
thin, and it was quite difficult. You had to like almost pump your hand to get, and then stab it all the way around the tooth. And then,
that's the one. You
yeah,
definitely don't want to be using anything large, like things that you use an ID block for. You're just not going to get the pressure or what you want. So you want to be using something very small. The gun's usually quite useful, but even if you do use your normal infiltration needle, I do find that actually works if it's not a really hot pulp, and you give it mesally and distally, like I said, because those are the best places to give those injections.
Yeah, I quite liked the way it worked, because you could edge your way around the tooth and give a little bit, and then you get to one spot and there'd be a little jump because you hit the bit that's not got anesthetized, and then there's instant relief, and then you've got it. So they're quite good. Caught my phone, it almost fell off the holder.
Can't get it fixed in lockdown.
I think it's actually do you know the thing that you put in your car windscreen?
Oh yeah.
But I put it on a desk, but the little disc underneath where it's sticky, I think it's starting to it's had its best days.
Oh, okay.
I might have to get one which clamps onto the actual desk, which might be better. Ismail saying good luck on the records of that study once they're out of pain. Yeah, sure.
Yeah, exactly. Do you know what I mean?
Thing.
They don't come back. It's really difficult.
Yeah, so I think that's the kind of most of Perio Endo kind of covered there, really.
Yeah, I mean, I'm just trying to think if I'd had anything else to say. I guess the last bit is just the true combined lesions, which means that you have a little bit of endo. You've got some endo disease, you've got some perio disease, and they join together. And that's sort of the only other one that's very difficult to fix. So you've got a very poor prognosis on those cases. And I guess your last sort of treatment option for these cases, I know we talked about doing the endo first always, and then coming back and doing the perio once you've got as much healing as you can of the endo part of it, would be sort of hemisections and root resections if the perio can't be solved and you've got a multi-rooted tooth, which sometimes works quite well. So yeah, I think those are the main points covered.
Do you ever use any antibiotics actually for these kinds of cases? I think that's probably the only thing we've not spoke about.
No, not from an endo point of view. No. So, I mean, look, I quite often work with periodontists. I don't think that they use antibiotics for these sorts of cases either, but I can't be sure. We can ask Rena tomorrow to see. But from an endo point of view, no, I don't. I mean, I find that the endo part is the more predictable part. It will resolve with root canal treatment because we've got rid of any necrotic tissue that's in there. I think the challenging part of these cases is the perio side of them.
Yeah, I think that's the thing. Obviously, the perio guys have got the perio chip, perio stat. Whether they're still using those or not, I'm not entirely sure. I'm not quite up to date with state of play with those.
I mean, even things like I think their guided tissue regeneration is very difficult for these sorts of cases because it's a multi-walled defect. So, without talking too much about sort of perio, I think guided tissue regeneration is very difficult. But antibiotics and lasers and things, I don't know how well they work in the perio side of things.
No. Hass is in the comments. Hey man, how you doing? Adonis just said developmental grooves.
Yeah, so that quite often we find these in sort of upper central or lateral incisors. And these teeth can stay sort of asymptomatic for a long period of time. But because there is a groove that runs from sort of normally the CJ region to quite far up the root, as soon as you get a little bit of perio issues in that, in that region where you get the junctional epithelium that's lost, you'll get quite quick progression now of the perio disease up that developmental groove. So normally if I do see them, it's sort of prevention. So whenever you see laterals or centrals with developmental grooves, it's telling the patient they've got a groove there, telling them that oral hygiene there is really, really important, because as soon as that groove starts to develop any perio disease, you're looking at quite, quick progression of that. Unfortunately, very little treatment that can be done there, and again, mainly from a perio point of view.
Yeah, so a lot of this is kind of very mixed, and you need to be working alongside somebody who knows what they're doing on the perio side. Otherwise, it's almost pointless some of the bits that we do, because patient isn't motivated, perio is not being done correctly. It's just gonna, it's not gonna heal itself.
Yeah, it's a waste of their money to spend, to do the endo, and then things don't work out for them.
Sure. Yeah. Amra's got a question here. When do you do single visit endo, and when do you prefer 2 visits endo?
Yeah, so for me, it's single visit endo for nearly sort of 90-95% of my work. There's been big systematic reviews which have compared single visit endo versus multiple visit endo, and everything points to there's no significant difference between the two. If anything, single visit endo always comes out slightly better, but not significantly. And I think a lot of the sort of my reasons for doing single visit endo is one, patient factors. So they have to be in the chair once. No one likes having a root canal done. No. It's done in one go. They're finished, and it's back to the dentist for cuspal coverage restorations if they need it. The second thing is I get to put a definitive coronal seal in, and we know how important a coronal seal is. So I put a composite core in straight away. I'm less worried about that tooth breaking in the interim period, and I'm also not worried as much about any sort of leakage, because if a temporary filling is lost, quite often that as soon as the GP is exposed, within a couple of days we've got bacteria at the apex of the tooth. So I quite like the idea of single visit endo for these sorts of reasons. But multiple visit endo is also very good, and I occasionally do it things that there's a lot of exudate, and it's we can't get the canal dry to obturate. Sometimes for very, very large lesions, I'll tend to dress the tooth just to I don't think it makes a difference, but for peace of mind, I'll sometimes dress that tooth. But most of my work is single visit endo.
Yeah. Rashina's asking a question. EPT brand, what you use at the moment?
Oh, I think it's called Digitest. I think it's called Digitest, but I'll have to check that. I can't remember. If you haven't been at work, you forget everything.
Yeah. For sure.
I think it's Digitest though. Basically, the ones that are good are the ones that either you don't have to do lots of things with your hand at the same time. So there are ones which basically you put the metal on the tooth and you've got to twist something. They're more difficult because you need multiple hands for that. So I like the ones you can it's either the ones that you sort of press and the numbers, it goes higher on the test, or that the patient lets go of and automatically goes up, and the patient lets go of the metal thing they're holding on to.
Yeah, I think that's a pretty. It's really annoying, the little wheel thing, because they're trying to get it on the tooth and the patient's
and then you're trying to
holding tight, and they tighten up. So we're going to try. Well, I'm going to try and keep up this particular kind of podcasting after the lockdown ends.
Yeah, it's nice to see Hassan on this. Hi, Hassan.
I did a few back in September, but then we just dropped off. We did 3 one week apart, and then just did nothing until lockdown started. So hopefully I'm back. I'm in the swing of things now. We were doing those over Skype, and it was really, really difficult to get time, and then the Skype software was a nightmare. I think this is much more kind of, it's just easier. It's just easier,
isn't it? Yeah, it's all done for you. Yeah.
Absolute indication for an open dressing. We've got about 3 minutes left, guys.
So definitely if there is any exudate or bleeding coming from the canal, because you don't want to obturate a canal that's wet, because you won't get a good seal with your GP point. That's it. I mean, the only case that I definitely will dress other than that is if it's a retreatment that I'm doing and the initial treatment was very, very good and I can't improve it significantly. So I haven't found an extra canal or something like that, then often I will dress those teeth. Or if the patient is in pain towards the end of treatment. So for me, usually they don't feel anything throughout the whole treatment, but if towards the end they're still feeling it and I've numbed up adequately, those sorts of teeth that I will dress, but it's quite rare.
Yeah. We're going to be popping this on IGTV, so if anyone's missed the rest of the video, don't worry, that's going to go up as soon as I finish. And we had a question about, we always get this question, the rotary system. Have you used high flex? Is it better than pro taper, wave one, etc., etc.?
Yeah, I mean, I've used them all, done all their training courses and stuff. I think it's whatever works in your hands. They're all very different systems. They all have different feelings. And a lot of studies have been done on this sort of thing, like what system is better. And actually it's any system that, you're feeling comfortable that works in your hands. I think the only other thing is you just want something with not a huge taper, because we know we want to be more conservative with our prep if we can. So maybe, don't be finishing on like an F3 pro taper gold or something like that, but as long as you're reasonably conservative in your prep, whatever system that you want. My favorite is pro taper next, if anyone wants to know, but that's a personal opinion, what works in my hands.
I think it comes down to sometimes the case that you've got in front of you, and then again whatever you're used to and seem to be getting results with. I think that's pretty it doesn't really matter almost, as long as you're using the right bits and pieces and doing it correctly.
I mean, I find Pro Taper Next really good for curved canals, which is one of the reasons I use it, because I work on quite a lot of curved canals, and I find it quite conservative. It moves in like a snake-like motion, so it hits a lot of the dentine walls. I do like it, but there's loads of rotary systems out there that are good.
I can't disagree with anything you said there. I think Hass is in the comments again. Hey Kreena, Moxidon with deciduous, we spoke about it already. Get you something soon.
Kittens are good.
Diagnosis for a vital tooth with periapical lesion, so that's primary perio.
So again, you wouldn't be treating that with any sort. You just stay away from endo. You tell the patient that this actually doesn't need endo. This is fully, due to your perio, and either leave it to the periodontist, general dentist to deal with, or that, if the next step for that tooth is to take it out, because doing an endo is just not going to help anything in that case. The pulp is vital. It's not contributing to that infection.
And really, it shouldn't be too difficult to convince a patient they don't need a root canal.
No.
That's probably the best thing that they'll ever hear.
More difficult to convince the periodontist than the dentist.
For sure. No worries, Rashina. No, thank you for putting some questions in. If you've enjoyed today's, I've just got the 1:30 warning that we're about to get kicked off. If you enjoyed today, guys, please take a screenshot, pop it on your story, tag Kreena, tag myself, and I'll share it on my story as well. Thank you for coming on. I think we've done a pretty good job of Perio Endo. Not quite as exhaustive as last time. I think there's a little bit less to talk about than last time. But if anyone's got any questions, shoot one to me or to Kreena. We'll be happy to kind of help you out, guys.
Yeah, thanks for having me on.
Yeah, no worries. One question. We've got exactly 60 seconds. See if we manage to get it in. File retrieval system do you use and recommend?
So I really like the IRS system. It's a love-hate relationship with that. That's the instrument removal system. If you're in England, you can get it from QED, which are the main distributors of it. There's also their Tarucci ultrasonic kit, and there's like a loop system that comes with that, which is also very good. The only problem with that is the loop does tend to break, so you can't use it that often. And the ultrasonics, again, you have to be very delicate with the use of them. But yeah, those are I would say my go-to systems. I really do like the IRS system.
Awesome. Guys, thank you for joining us. Make sure you're following Kreena. If you're not following me, then you can do if you want. We're going live quite a lot. There's a schedule which is up. and please turn on the live notifications. Thanks so much for coming on, Kreena.
All right, nice to see you. Bye.
Awesome. See you guys. Thank you.